Good afternoon, everyone. If we could take our seats, please. For those of you in the back of the room, if you could please grab a seat. We're just waiting for everyone to sit down. We'll kick this off. Okay, well, welcome everyone. I'm Mark DeCourcy, the Senior Vice President of the U.S. Chamber of Commerce Foundation, and we're so glad that you're here today. We've got this great event planned, and our speakers are going to discuss issues pertaining to the mental health and mental well-being of Americans from across the country, and how the business community is doing and what the business community is doing to improve their lives. At the Chamber Foundation, we harness the power of business for solutions for the good of America and solutions for the good of the world. While there are many ways businesses can drive these solutions, health and mental well-being is one of the most important. Chuck, it's so good to be back with the National Council for Mental Well-Being. It's been 3 years since we've worked together, and we're so happy that they're here because they drive so many of these solutions for the business community all across America. We know that healthy employees are more engaged and more productive employees, and there are many ways in which the public and private sectors can work together to achieve these ends, both for Americans and the communities in which they reside. And as such, we can collectively do more to improve the mental health of our nation. There was a net result of that. We'll have a more productive and a stronger United States of America. So I'm pleased to be here with you today to explore these solutions for this national problem. And the mental and behavioral health crisis requires localized solutions, and this is really important. You have to have local solutions and a partnering with federal support to really get to the ends that you desire. So with all that, we'll have our first speaker, and I'm so delighted that she's here, Dr. Anita Everett. Dr. Everett has made her life's work to improve the nation's mental health. She is the director of the Center for Mental Health Services at SAMHSA, which I think all of you know is part of HHS. And she's had a really illustrious career, which we'll hear a little bit about, and how she's fighting to improve how we provide mental health services to all Americans. And we'll discuss how businesses and government can work together to achieve those ends. So with that, Dr. Everett, the floor is yours.
Thank you so much for having me here. I'm so excited to be here. This is one of my very favorite projects to talk about here today. So again, I want to thank you. As was mentioned, I am a community psychiatrist. I've worked in various settings, both delivering care and also administration at the local government, county-based level, state, and also now more recently federal. I've worked in very rural areas, health underserved areas, and also in very urban areas, most recently Baltimore, before returning to census. So I've done a lot of different things across my career, and I've really never seen anything quite like the CCBHC movement, I want to say. So I do serve, as was mentioned, as the director for the Center for Mental Health Services at a federal agency called SAMHSA, and our agency works very closely with CMS, Center for Medicare and Medicaid Services, on various developments that have to do with the CCBHC model. So we're very tied in with working hand in hand with CMS on the different aspects of this particular model. One of the history points that I like to talk about when I talk just a little bit about the CCBHC model is to remind us that one of the things we're celebrating this year in the field of public mental health services is the original passage of the Community Mental Health Center Services Act, which happened 60 years ago in 1963. By then President Kennedy. It was signed into law, one of the last things that he signed before his assassination. It was part of a whole new vision that had many aspects to it, including the moonshot. And one of those was, of course, a life in a community for individuals who may have otherwise been institutionalized. So since then, really, for 60 years, our system, the public mental health system or mental health system at large, has been described by various terms that include things like shambles, far too much inequality with regards to who has access to what, and far too dependent on where you live. And in my mind, the CCBHC model, which we're now working with and proposing, is really a full-on answer and the best shot we've had really in 60 years, or maybe it's 55 because CCBHCs, we've been working on those for so long, really are the vision that was worked on and originally envisioned 60 years ago. So this is really a very cool thing. Let me provide a bit of an overview for what a CCBHC is, and I know we've got some experts later in the panel that are going to talk a little bit more specifically about it. But what's so exciting about this is it does provide a standardized list of services that are to be provided. So it moves away from the idea that if you live here, well, you can't really have that kind of case management, or you can't really have that kind of supported housing or those kinds of services. It creates a standard expectation no matter where you live for those services. There's 9 different types of services clinically that are required. It also has quality metrics that are a component of it. It provides care for anyone, much similar in many ways to the way the Community Health Center initiative works. CCBHCs see everyone irrespective of their ability to pay. That's a requirement. And they also see the full age range, so from kids all the way up to old age Americans or old age adults. So they're required to see that. Another really unique and very important opportunity or aspect of the CCBHC model at large is the access points that it creates. We know, and I think, if each of you think back about some of the issues that you've experienced, family members have experienced, or you have heard about through your employers, employees, neighbors, those kinds of things, accessing the mental health system right now is really a challenge. CCBHCs require the operation of crisis services directly or with an arrangement with the local mental health crisis provider. And they also require appointment scheduling that's with no later than 10 days from the time of first call. So in places that don't have CCBHCs, for instance, it's not unusual to be told you're on a waiting list and it'll take about 6 weeks for your next appointment. That varies, of course, by community. So CCBHCs, I say, one of the ways I firmly think about CCBHCs is it's where you would want a family member. Were you in a situation where you yourself, a family member, a neighbor's child, a neighbor's relative, needed mental health services? A CCBHC is where you would want this person to be able to go. So I do consider this to be a game changer for the mental health system. One of the other aspects of CCBHCs is the cost reimbursement that is a different kind of arrangement with Medicaid. For certain of the CCBHCs that are in states that have adopted what we call the demonstration model, they actually get cost-based payment. There's generally a monthly statement of the total cost to deliver care within parameters that are established is submitted, and that amount is paid for. So that results in overall higher reimbursement for the communities. The CCBHCs are the entities that provide services through the CCBHC. And later on, I have some statistics about what this has resulted in, but it really does increase the ability of community mental health centers to meet the needs of individuals. As I said before, access is an important key component and a real problem, a chronic problem in our mental health services system that the CCBHC directly aims to follow. Many of the CCBHCs, so we do require at least within 10 days that they provide service. Many of them actually have walk-in clinics that are outside of the regular crisis services, so you can, in effect, like an urgent care, sort of walk in and have an initial appointment with one of their credentialed staff. Let's see, so the Medicaid, the reimbursement. I want to just have a little bit of a highlight about the brief history. So it was originally implemented, the CCBHC demo model, the version of CCBHCs that have this increased payment arrangement, was originally only eligible in 8 states. And then 2 more states got added, Kentucky and Michigan, so that now there are 10 states that are participating in this. However, recently, in the 2022 Bipartisan Safer Communities Act, or BISCA we call it, the demonstration, that act enabled the expansion to include 10 new states every year in a rolling kind of fashion every other year until virtually all the states are run through. And later I know that you'll be working with or hearing from Senator Stabenow. You can thank her with full confidence that she was one of the main champions of these kinds of provisions in the federal law that support that. She didn't do that by herself. There were a number of other elected officials that are very much behind that, but it's a very important model and always, always helpful when you have high-level champions that really get the model and really see it as a problem solver. We at SAMHSA work together with CMS, and we have a special situation that was a competitive application process that will allow 10 states to develop what's called a planning document series for the adoption of the CCBHC model, the transformation, in other words, of their existing Medicaid plan to become a CCBHC. And I say Medicaid because a lot of the recipients of services in these are Medicaid, but there's nothing that prohibits any kind of commercial insurance or any other carrier from paying for these services. And actually, if a person has no assets, there's a sliding scale fee that's worked out that's a mandatory component of that. So these 10 states that we'll be working with really closely are Alabama, Delaware, Georgia, Iowa, Kansas, Maine, Mississippi, Montana, New Hampshire, New Mexico, North Carolina, Ohio, Rhode Island, Vermont, and West Virginia. And many of these states are states that have been eyeing the CCBHC model for a long time and now have a chance to sort of jump on the planning and get more detailed with regards to exactly how they'll transform the system. We are making other opportunities for states that are interested that weren't in that original sort of competitive cohort process to participate in some ways, and I'm happy to answer questions about this later. So one of the other things that we've worked on recently, very closely actually with the National Council staff and the other stakeholders that are very involved, hopefully some of you actually were involved with this, is a revision of our the credentialing, the criterion, the certification criterion for CCBHCs. The original set of criterion was developed maybe 7 to 8 years ago, and there's certain things that have happened in the world that needed to be updated. And so 3 of the broad themes that we've updated in the criterion that was just released in the last couple months and is available on our website include a really strengthening of the language that we had about crisis systems. So much has happened in the last little bit with regards to 988 evolving and developing, and money that we've been able to support states with in the planning of a fuller crisis system, mobile crisis units, and also alternatives in some areas that where an individual might go as an alternative to an emergency room to try and diminish some of the boarding situation that we have for too many individuals waiting for beds. So crisis is one thing that's developed and worked out a little bit more in this new revised certification criterion. We've also ramped up the substance use treatment that's required. We do require medication-assisted treatment for opioid use disorder. More recently, we also include medication-assisted treatment for smoking cessation. We had a debate about that, to be honest, but that still remains a very important health risk factor for many of the people that are served by our clinics, and so we want to make sure clinics have staff on them that can provide MOUD or medication-assisted opioid use disorder treatment, as well as for smoking cessation. And then the third of the 3 areas that are updated in the criterion include a stronger emphasis, which is very consistent with this administration, the Biden administration, on underserved and underserved communities, and assuring that the CCBHCs are full on in their recognition of the need to make sure that they serve populations from across their entire community, not just just a select few or those kinds of selection criterion, just so that it's very fair and all individuals have equal access to the services. CCBHCs do require crisis services as a component of them. And I think I mentioned just a little bit about that. They require some relation. Many of the CCBHCs actually are the state's 988 call coordinating centers, but that's not a requirement at all. They just have to have some relationship with the call center so that their individuals, because they are required to offer mobile crisis services. Either directly or through referral, 98% of the respondents to a survey that was recently conducted by the National Council offers access to 24/7 crisis lines. 97% offer access to mobile crisis response. That is a responder that at least has one behavioral health trained person that will go to the site of a crisis, and 94% offer access to crisis stabilization services. And as I said, many CCBHCs serve as 988 call centers. On CCBHCs in the private sector, we are here today, the Chamber of Commerce, which involves, of course, what we would call private sector as well as other government sector. And we know that, the private sector partnership is very important in promoting what the CCBHCs are, how they might be accessed by relevant employees, employers, and or other even entities in the community. It occurred to me that this might even be a recruitment tool. I know Chamber of Commerce members are often involved in trying to promote onset or uptake of new businesses and things like that in their communities, or welcoming new individuals, and being able to brag a bit about a mental health system or mental health services could be an asset in the roles that some Chamber of Commerce's play at a local level. Now I want to close with a couple statistics that I have that are just sort of broadly give a picture of some of the good news, or the statistics, or the outcomes, I guess you'd say, of the CCBHC clinics, the CCBHC, we might even call it movement. By the way, I didn't think I mentioned this, but there are at least 500 CCBHCs across the country, and this is growing all the time. And so we're on a roll, so to speak, with regards to uptake and broad development of the CCBHCs across the entire United States. And that's very much our intention. We say that individuals with a serious mental illness, any kind of mental illness, no matter what age, should be able to access a fair amount of services, have good access to high quality services. So to date, 2.1 million people are served by CCBHCs as of August of 2022. Because of becoming a CCBHC and the attention that they get with regards to looking at their front door or the access points, 23% more people are able to be served on average per clinic. So that means a clinic that was serving 100 people before could now serve 123 people, because of the way they more efficiently organize their inputs, their intake processes. And an average of 27 new staff positions per clinic are created. And mostly these staff positions are at competitive salary rates, which is a big, chronic problem for us who work in these types of clinics. As a result of becoming the peer support specialists, were another component of the workforce that's turned out to be extremely valuable. Let's see, where are my statistics on that? 84% of CCBHCs added in peers to their existing staff as a way to augment the needs. Primarily their role often is involved with recovery support, but to augment the recovery support needs of staff. 82% of CCBHCs and grantees use one or more forms of MAT, so as I mentioned earlier, that is a required element. This, by the way, is more than the substance abuse clinics, which typically, by our statistics, only serve about half, or 56% of individuals serve MAT. So if you have an opioid use disorder, or have someone in your life that has an opioid use disorder, and you go to a CCBHC, you're more likely to get MAT than if you went to a regular addiction treatment unit or center. Children and youth, as I said, are part of the service component, and nearly 3 in 5, or 58%, are currently engaged in, plan to engage in, or work on housing directly. So we know that's an essential component. These days we're calling it a social determinant of health. I think those of us who've worked in the field have known that for years, but now it's becoming more and more apparent that without housing, without employment for those who are interested in employment, really you can't sustain successful recovery. And so those elements are extremely important. So these data are really impressive, I think. They really are early data for what we see as a very clear national movement. And I know, the panel that will come after me will get a little bit more into the details of the experiences and successes and maybe challenges that they've had with regards to the CCBHC model. I really want you to know that we here, I represent SAMHSA, the federal agency in charge, that administers the components of the CCBHC model. We're behind this model 100%. If there's anything I can do personally or across my team to facilitate questions that you have about CCBHCs or any other kind of need that you have, please reach out directly. I'm very happy to talk with you and communicate with you. This is a really important model that I do think, in summary, is a game changer. I think of it as very much a game changer for mental health services. So thank you. And with that, I think turn over to the panel.